Hello and welcome. In this video, we're going to talk about the basics of what is radiation therapy. All right, let's start by defining some very basic terms. First off, radiation therapy. So radiation therapy is the use of ionizing radiation, and there's multiple types of ionizing radiation that could be used to treat disease. That's typically going to be cancer. Sometimes we will shorten this and say radiotherapy. So if you hear radiation therapy or radiotherapy, really we're talking about the same thing. Radiation oncology, technically oncology is specific to the treatment of cancer, but in practice this term is used interchangeably with radiation therapy, radiotherapy. When we mention these, we're usually talking about the ionizing radiation to treat disease, typically cancer. And just to cover the basics, what do we mean by ionizing radiation? Well, light can be divided by energy, and we have radio waves, microwaves, infrared, and then visible light, and then we have what we would call ionizing radiation. And this radiation includes ultraviolet, X-rays, gamma rays, and the main characteristic here is that the photons are energetic enough to affect individual atoms, right? So you can have ionizing events that happen in individual atoms when this radiation interacts with an atom. So why do we use ionizing radiation versus any other type of radiation? Well, the first reason is that ionizing radiation can preferentially kill cancer cells. So radiation damages the DNA via ionization events. There's single-strand breaks and double-strand breaks, as shown in the bottom left figure there. And also, rapidly dividing cells have less opportunity to repair the damage, which makes them more sensitive than slower dividing cells. And cancer is, by definition, it's growing kind of out of control. It doesn't really stop to repair damage, so it puts it in this more sensitive category generally. The other reason that we use ionizing radiation is that it can penetrate through the patient. This image here is basically the first medical X-ray taken by Wilhelm Röntgen of his wife's hand, right? And so these X-rays, as we know, can travel through the body. And so that allows us to be able to treat something without an invasive procedure by the X-rays penetrating into the patient. So one common confusion is radiation oncology and radiology, and these are not the same thing. But it's understandable that people have they use these terms interchangeably or don't really understand the difference because they both do deal with radiation. But radiation oncology differs from radiology in a number of ways. First off, radiation oncology deals with the treatment of disease, whereas radiology deals with the diagnosis of the disease. Radiation oncology, we're talking about photon energies in the megavoltage range, which are about 1,000 times greater than the photon energies we're using in radiology for basically diagnostic CTs and X-rays. The megavoltage range we use in radiation oncology because it has better penetration and skin sparing. In radiology, if we're talking about CTs and X-rays, the kV range has a larger attenuation difference between tissue and bone. So that's why you're able to see bones really well on an X-ray. If you did that with an MV image, which we do sometimes, you don't see as much contrast. And then also the dose is quite different. So the treatment dose that we're talking about for radiation oncology is on the order of 2 to 80 gray. Usually it's fractionated in some way, 2 gray per fraction. Or 1.8 gray per fraction up to 5 gray per fraction. There is imaging dose for radiation oncology, but really it's minimal compared to the treatment dose. And that imaging dose for radiology studies is on the order of 0 to 5 centigray. So as you can see, it's quite a bit larger for radiation oncology than what we would typically talk about for doses in radiology. All right, radiotherapy can be divided into 2 major modes. One is teletherapy, or external beam radiotherapy, EBRT, and the other is brachytherapy. So teletherapy, tele meaning like far, brachy meaning close. Teletherapy is basically when you have a source that's outside the body and it's aiming it in. And typically what you'll do is you'll aim it, and then if it's at depth, you may aim it from different directions to get kind of focus it on one area. And there's a bunch of different types of teletherapy that we could use. So photons is probably the most common. Electrons are typically used for more superficial treatments. Orthovoltage, not used as commonly anymore, but also kind of a superficial treatment. Protons are becoming more common and have some unique advantages. Heavy ion external beam is similar to protons, but maybe less common and maybe has some other subtle advantages, disadvantages. And then there's neutrons as well, but that's kind of a very rare type of treatment. And then for brachytherapy, basically in this case, you're taking the source and you're putting it directly into the tumor. And that's how you're achieving kind of this advantageous geometry for your dose. And that can be an intracavitary treatment. It could be interstitial. It could be kind of a permanent seed implant. It could also be intraoperative. Now, you could also break brachytherapy into two other categories, which would be high dose rate and low dose rate. And then there's some kind of variations on those, but those are kind of the main two. High dose rate being kind of a really high dose, and it's given kind of maybe fractionated, and then a low dose rate where it's kind of given, the dose is accumulated pretty slowly relative to the repair, and the dose is delivered over a longer period of time, whether that's on the days or kind of a permanent implant type of treatment. So our goal in radiotherapy is to give a high dose to the tumor and minimize the dose to the surrounding structures. And there's a few radiotherapy treatment planning strategies that we can do to apply this. And let's take a look at a couple of examples. So here on the left, this is a photon external beam radiotherapy. Basically, we're achieving a high dose to the prostate, which is the target in this case, by using multiple megavoltage photon beams, which are aimed from different directions, all focused on the target. So even though maybe the dose in this case, if you had a single beam, would be highest at the surface and then, or near the surface, and then kind of decrease exponentially, by using multiple beams, we're getting a high dose at the center there. The second example here is for proton external beam radiotherapy. In this case, we are achieving a high dose using two proton beams and using what's called the Bragg peak located at the target. And this Bragg peak basically is where the dose is highest near the end of the range of the proton beam. It's a unique characteristic of protons and heavy ion beams. And then this last example here is a brachytherapy permanent seed implant. So in this case, we have low energy iodine 125 seeds that are implanted directly into the target. And those are, in this case, permanent, but you could also have temporary treatment as well. Basically, you're putting the source directly into the target to achieve this high dose at the target and low dose outside of that. So all of these are kind of radiotherapy strategies that we can use to give a high dose and localize our dose to a target and minimize dose outside of that area.